Thank you so much, Jennifer and Annamarie. If you want to kind of drop off, you might even move over so you're not blocked by this. But yeah, we now have a bit of time for questions from the audience. And Bill has some mics in there. I think there's some other people who have, there, Leora, who has over on there. So if people had any particular kind of questions, just gesture to them for any particular kind of questions that people might have for clarification or thoughts. Or Bill may have some questions as well. But any kind of pressing people for particular kind of questions?
While people are thinking about questions, I'll just open with one and direct this to Jennifer. Annamarie, you can jump in as well. You allude to Denmark having a system, sounds like a good system. They're not doing a whole bunch of unnecessary tests, and they have integration and are quite mature in all those dimensions. What have they done, and what has the history been in their own transition? And we know that there are other countries that have achieved high levels of e-health penetration. What is the roadmap that those countries have followed?
I didn't go to Denmark to be a patient, but I probably learned more about health policy. Is this on, by the way? Can you guys hear me in the back? Yeah, okay. I probably learned more about health information and health policy by being a patient there. So day one in the country, my relocation angel is holding my hand to go around and register for all the various things, because you need to register for a lot in Denmark. And one of the things you register for is you register for your physician, your primary care physician. And so here's my first surprise. A, there's a registry of physicians accepting new patients, that everyone on that registry, if I pick them, they take me. B, that list actually includes on it information about not just where they are they male or female, those kind of questions, but also, do they allow online appointment booking? Do they allow prescription renewals, emails, and so on? And my relocation agent, who had met me that morning, knew nothing, said, you should pick this doctor. Okay, care to tell me why? Because of course I can't read the list, right? And she says, well, it's because they offer these services. And so it's become so much of an expectation, I think, that is just the way we do care. And another good, they started really in primary care and built out from there. And what they would tell you about the history is one of the big drivers was that in Denmark there's a sort of shared after-hours service. And so clinicians participate in that, and they got electronic records through that shared after-hours service. And then they started saying, well, this is crazy. How come I have better access to information about my patients after 6 o'clock than I do during the day? And so there was a big driver then for sort of broader-based adoption as well.
And introduce yourselves as you ask your questions.
Okay, hi. Kim Kelly, I'm with the Alberta Medical Association. Something Jennifer said at the end about the early adopters, I think is a big piece. So I just wondered if you had advice with your various stakeholders. If the early adopters get too far ahead of the greater majority, you're going to lose people. So just wondered if you had lessons learned with the various stakeholders to change management.
I think it's an important question, because I think one of the things that change theory and the experience teaches us is that the things that are helpful for early adopters are not necessarily the same things that are needed by the early majority, the late majority, or late adopters. And so the approaches to change management, the ways that we work together, the kinds of tools in our toolbox need to be responsive to that as well. And I think it's learning from the experience of early adopters that can teach us a ton, but then recognizing that we may need to adapt our strategies as we go along as well.
And from some of the experiences I've had as well, some of the really resistant folks who are just, hands crossed like this, not going to participate, are often very compelling in some of the things that they bring to the table for discussion. When we're looking at change management, I've been in healthcare, like I said, for 30 years, and I've seen vast amounts of change. And almost every time I've been involved in change strategies, whether they were IMIT strategies or clinical process strategies, the person at the back of the room with their arms crossed was usually someone I needed to talk to. So the early adopters bring the enthusiasm and the excitement and some of those things that keep us moving forward in a certain direction. but those people, the people that hesitate and bring caution to the table, almost always have brought some great wisdom and taken us in a slightly different direction.
Just over here.
Thank you. So my name is Catherine Andruski. I'm a family physician and with the Alberta Medical Association. Hi, Annamarie.
Hi.
It's good to see you. So one of my concerns has always been, how do we protect patient confidentiality? Because when patients come to see me and tell me their issues, they're not necessarily consenting to have that released to all healthcare providers in the province. So I'm just wondering, how do we face those sort of challenges? Not all data is the data that should be out there. So not more access, more access is not always better, is what I'm trying to say there, that we do need to protect those relationships that, you know, patients entrust us with.
You know, it's a tough one because, you know, I've had great ethical conversations with other healthcare professionals around access. And when I was with the Health Quality Council Board, we talked a lot about the ethics of widespread availability of patient information. What I'll also say, though, is that as a patient, I just assume that that information is out there and available. I also have a chronic illness, and I won't go into any detail, but I'll say that recently I saw a specialist in another city, and it took quite some time to see her. But when I got there, she was able to pull information from my chart from 20 years ago. And it's not that I was astounded that she had access, because I expected her to, but what astounded me is that she had as much access to information that I had long forgotten. So I think that that's one example of patients assuming that all providers that are helping me care for myself have that access. My husband, who you've all heard about a few minutes ago, sees his pharmacist a couple of times a year, and she spent 2.5 hours with him developing a care plan after he got sick a year ago. And she updates his care plan. So she has access. So I understand the ethics of it, and I know that more access is not always better, but I think that those issues around security and privacy can be addressed. And I hope I'm not sounding like Pollyanna with my pigtails too tight, but I think that we can get there.
I think there's just a quick, oh, did you have a comment, Jennifer? Okay, just over here.
Hi, Sean McCann, Primary Health Care with Alberta Health Services. It's really good for patients to have access to their numbers, to their test results. I'm wondering about your thoughts about what to do about those test results. What do I do, where do I go, and that sort of co-designed care plan, and having access to that so that they can keep referring back to it.
I think one of the things that we've learned from BC, for example, that's moved forward and has broad access, is that you change the way that you provide care. So physicians there will tell you they change the way they do consent now for lab test results. So rather than saying, we'll talk about it when you get the results, they may say, here's what it means, here's what you might do. So it changes some of the conversations and changes the flow in terms of how that pattern happens. The other thing where there's been a number of questions that came up was people were worried, would this actually increase anxiety? So would having that information cause people to worry or do other things? And really interesting study looked at matched groups of people who had chosen to have access and who didn't. The people who had access were more anxious beforehand. So if you were more anxious, you were more likely to have chosen to have the access. But after you had the results, there was no difference in anxiety. So effectively, those people spent a shorter period in an anxious state, which I think was a really interesting finding from what's the real on-the-ground experience when you go at scale with these kinds of initiatives.
Just piggybacking on that, do either of you want to comment on the notion of full access to the full record for patients versus some kind of filtered, laundered record that paternalistically filters content?
Oh boy, I have an opinion.
I mean, I asked the question in a loaded way,
yeah,
but
not at all.
But forget about how I asked it. So comment.
Actually, full access. I think a couple things are in play. I think that full access makes people a little bit nervous because we have practice patterns that are entrenched for dozens of, well, a few generations. So those practice patterns are going to need to change, I'm sure, to support full access. But the other thing too is the average patient isn't, like, I think most patients are going to look at diagnostic imaging, specialist referral information, a lab result, something like that. Full access, I don't know. I don't see patients diving really deeply into their charts. Some will, and if they do, they'll learn more. There's assumptions, like I mentioned, there's assumptions that can be made in a chart note that are incorrect. It's happened to me, and a physician has said to me, "What about blah blah blah?" And I said, "Actually, that's never happened. That was not, my information or my story." So I think that those patients who do have full access, I think the advantages are significant and the risks are small. But again, I'm a Pollyanna.
Maybe just to add to that, I think we have an interesting set of experiences, both with the open notes environment in the US, which was open access to the full notes, and also with experiences here in Canada, where some organizations have moved forward in the same way, including, I think, some really interesting experiences in mental health with Ontario Shores that's broadly opened up their records. And what clinicians tell us is that it does change some ways that you document in the record. So you may document more clearly, you may use fewer abbreviations, those kinds of things. But at the end of the day, what the result seems to be is more trust. Yeah. Particularly in that mental health setting, they talk about the fact that there's no secrets behind doors. This is a care plan we've developed together. And it's something that's open to patients to see and to contribute to.
Okay, and this would be the last question just over here. Okay.
Miles Leslie from the School of Public Policy in Calgary. Thanks very much, both of you. A question, it's a copy-paste question on your Denmark experience. Your line was that it was primary care-led. The cliche here is that we're more hospital-led. How do you see any copy-paste issues or lessons that could be learned about how to take a more hospital-led system and try to come up with a Denmark-style result?
I mean, Denmark did both. So they started in primary care, but also included acute care and other aspects. They would also be the first to say, though, that they're not done. This is a journey that they're on as well. And so it was ironic because about 2 months before I came back, I had a group of Danes who came to me who wanted to set up a study tour to Canada to understand what we were doing, particularly around telehealth and telehome care and health information exchange. And I got a call from a group in Canada who I knew who wanted to come to Denmark to have a study tour to look at what was happening in primary care, what was happening with patient online services. So I think every country I've been to, and I had the luxury when I was in Denmark of working internationally, so I was able to get to a lot. We're all aiming in the same general direction, but the paths and the routes that we take will be a bit different in terms of what we put first, what we put second, and how we do some of those things, because the nature of our health system is different. But I think one of the things we can learn from is we can learn from the Danish experience of saying, how do we do this for everyone? And how do we make this something that citizens in general can have an ability to access and can have an ability to engage with in conjunction with their care teams?
Mm-hmm.